Let's talk about a lumbar puncture, or an LP. A lumbar puncture is insertion of a needle into the subarachnoid space to obtain specimens, to relieve pressure, or to inject dye or medications. The type of things you need to know and may be tested on the NCLEX are: how do you get the patient ready for an LP? What is the procedure? What is the care after the procedure? And what complications are you looking to prevent? So let's talk about getting the patient ready for a lumbar puncture. First of all, you want to position in the lateral recumbent fetal position at the edge of the bed. So they're on their side in a fetal position at the edge of the bed so the physician can work there. What the physician does is he inserts a needle between the third and fourth, or the fourth and fifth lumbar vertebrae. So, and they take specimens, or they inject things, or they do whatever it is that they're looking to do. After the procedure is over, after the LP has been completed, what you want to do, and again this is very important, is you want to do a neurological assessment every 15 to 30 minutes to make sure that the patient is stable. The patient will be positioned in the prone position, meaning on their face, for 2 to 3 hours, and fluids are encouraged. Now, some patients experience a headache after a lumbar puncture is done. And usually if they have a headache after this, it's worse when they're sitting or standing, and it gets better if they're flat in bed. And the reason for a headache following a lumbar puncture is that there is leakage of the cerebrospinal fluid at the puncture site. So the fluid kind of leaks there, and what happens is then the amount of cerebrospinal fluid that bathes the brain or supplies the brain is less than it should be, and the brain is unstabilized. So if the physician takes more than 20 milliliters of solution, more than that is removed during the LP, you will position the patient prone for 2 hours, then sideline for 2 to 3 hours, then supine or prone for 6 hours. Again, this is done to prevent the headache that may occur after the procedure. If the patient experiences a headache, it is managed by bed rest, analgesics, and hydration. And again, you want to check the site for drainage. The next diagnostic procedure we're going to talk about is an electroencephalogram, or EEG. This records the electrical activity of the brain and is used to diagnose seizure disorders, to evaluate patients in coma, patients with organic brain syndrome, and is used to determine brain death. What they do for an EEG is electrodes are applied to the scalp to record the electrical activity of the brain. To get the patient ready for an EEG, tranquilizers and stimulant medications are withheld for 24 to 48 hours before the procedure is performed. Stimulants such as caffeine, chocolate, cola, cigarettes are withheld for 24 hours before the test is done. During the test, the patient, if they're able and awake, may be asked to hyperventilate. Now, meals are not withheld during the test because if the patient becomes hypoglycemic, it might change the outcome or the brain wave pattern. So meals are administered regularly or as needed before the test is done. But the patient may be kept awake the night before the test because in some of the tests they have the patient sleep and they need to be tired enough that they can sleep during the test. When they start the test, they will get a baseline reading when the patient with the patient when they lie flat with their eyes closed. Then they will experience or show the patient flashing lights or ask them to hyperventilate for 3 to 4 minutes. And what they're looking for is they're looking to establish seizure potentials or what would cause the patient to have seizures. Other things with an EEG, after the test, you want to help the patient remove the paste from their hair where the electrodes were applied. Any medications that were withheld before the test should be administered after the test. And you do want to observe the patient for seizure activity. Again, many patients who undergo an EEG have seizure problems, so you want to monitor for that after the procedure is over. Let's talk about a CT scan. You'll remember that a CT is a narrow X-ray beam that is used to provide images of structures. It detects hemorrhage, infarctions, abscesses, and tumors. Getting someone ready for a CT scan, you need to find out if they're going to use dye for the procedure. because if dye is going to be used, you need to let the patient know before they go to the test that when the dye is injected, they may feel a feeling of warmth, they may become flushed, and they may experience the metallic taste when the dye is injected. After the test is over, after the CT scan, you want to assess for any allergic reaction to the dye and encourage the patient to have fluids, again to 3,000 cc's a day. Another test that's done, but not as often as it used to be because of all the improvement of other diagnostic tests, but that's the myelogram. A myelogram is an X-ray of the subarachnoid space taken after the injection of dye through a lumbar puncture. Getting someone ready for a myelogram, they are NPO for 4 to 6 hours before the test. Phenothiazides, central nervous system depressants, and stimulants are withheld before the test. And you need to let the patient know that during the test the table is going to be moved so they know what to expect. After the myelogram is over, you want to do a neuro assessment every 2 to 4 hours to make sure that there's no changes. When the patient comes back, you will position them with their head raised 30 to 45 degrees for the first 3 hours after the procedure. And again, you want to encourage fluids. You also want to check the patient's ability to void. And the untoward effects that may occur after a myelogram are headache, fever, stiff neck, and photophobia. Let's talk about a liver biopsy. A liver biopsy is removal of a tissue sample by needle aspiration. What you need to know and what's frequently tested is, how do you get a patient ready for a liver biopsy? How is the procedure performed? What's the care after the procedure? And what complications are you looking to avoid? So let's talk about getting someone ready for a liver biopsy. Many patients with liver disease that are going to have a liver biopsy, they may need to have vitamin K administered IM before the procedure is done because of the danger of hemorrhage. Remember, the liver is a highly vascular organ, so they may get aquamaphytin or vitamin K IM before the procedure. The patient's NPO for about 6 hours before the procedure is done. They're given a sedative, and then for the procedure they are positioned supine lateral with their arms elevated. They're asked to hold their breath 5 to 10 seconds when the needle is inserted. After the test is over, you want to position the patient on their right side for 2 to 3 hours with a pillow under the costal margin. This is again to put pressure on the site so that hemorrhage does not occur. And the patient should stay immobile. You'll check vital signs. You want to check clotting time and platelets and hematocrit. And any severe abdominal pain should be immediately reported. Again, when they come back, you're going to check pulse and blood pressure, usually every 10 to 15 minutes for an hour, and then every half hour for the next 2 hours or so until the patient is stable. The complications are bleeding, and again, that's a very real complication you're looking to prevent, or bile peritonitis. And when the patient is discharged after a liver biopsy, they need to know to avoid heavy lifting or straining for at least 1 week after the procedure. Let's talk about a stomach or esophagus endoscopy. Remember, this type of endoscopy is a visualization of the esophagus and stomach using a lighted, flexible fiber optic tube. Getting a person ready for a stomach or esophagus endoscopy, they should be NPO for 8 hours. And they use a local anesthetic, so you need to let the patient know that their throat area will be numb. After the procedure is over, the patient will remain NPO until the gag reflex returns. What you're doing after the procedure is you'll be checking for vomiting of blood and checking for respiratory distress, because those are the complications you want to make sure and avoid. And let the patient know that they're going to have a sore throat for probably the first 3 to 4 days. It's not unusual, but then it should subside. The next diagnostic test we're going to talk about is a sigmoidoscopy. A sigmoidoscopy is where they use a lighted endoscope to visualize the sigmoid colon, the rectum, and the anal canal. Getting someone ready for a sigmoidoscopy, they will have or be ordered a laxative the night before the exam and have enemas or a suppository the morning of the exam. They'll also be NPO from midnight of the day before the exam. After the test is over, you will allow the patient to rest. You want to monitor for hemorrhage because that's one of the complications you're hoping to prevent. And you want to encourage fluids for the patient, again, 3,000 cc's. Let's talk about a colonoscopy. A colonoscopy is use of an endoscope to directly visualize the colon. A colonoscopy can be used as a diagnostic aid. It can be used to remove foreign bodies, polyps, or it can be used to obtain a tissue sample or a biopsy. What you do to get someone ready for a colonoscopy is they will be on a clear liquid diet for 24 to 72 hours before the test is performed. They will receive a cathartic each evening for 2 nights prior to the day of the test. They will have an enema the morning of the exam, so that's one procedure or prep. Or they can be on a clear liquid diet from noon the day before the test and take a Go Lightly, or what's considered or called Go Lightly solution, which is a lavage solution, the day before the test. And this is a solution used to cleanse the bowel. Patients that are receiving anticoagulant therapy, it is contraindicated for them to have a colonoscopy due to the risk of bleeding. So you'd want to make sure and check the patient's history before you worked with them for the preparation. After the colonoscopy is over, the complications you're looking for are hemorrhage and perforation of the intestine, so you will check for hemorrhage and you will check for respiratory distress. Often the patient will have follow-up x-rays and they can resume their normal diet. Let's talk about a gastric aspirate. Gastric aspirate is where they aspirate gastric contents. What they're looking for is blood, abnormal bacteria, and abnormal pH or malignant cells. Getting a person ready for a gastric aspirate, they will be NPO for 8 to 12 hours before the procedure is done. What they do is they pass a tube and they aspirate stomach contents through the NG tube. Histamine may be given to the patient because that stimulates the secretion of gastric secretions. And then they will collect samples every 15 minutes for about an hour to see what response the gastric area did. And the results are checked for blood and the pH is measured. After a gastric aspirate, there are just comfort measures for the patient and you should encourage fluids. An upper GI series is also known as a barium swallow. This is the ingestion of barium to evaluate the esophagus, the stomach, and the rate of passage into the small bowel. Preparation for this is they will be on a low residue diet for 1 to 2 days. They'll be on a clear liquid diet the day before. They'll be NPO at midnight. They'll have enemas until clear the morning of the test. And you need to let the patient know that after the barium swallow, their stool will be light-colored because of the presence of barium. It's not unusual. In fact, it's good. You want the barium to pass. Now, if a patient's going to have both a barium enema and an upper GI series, you want to make sure that the barium enema is done before the upper GI series. Okay, after an upper GI series, what you will do for the patient is you want to encourage fluids. Laxatives are given to prevent constipation because you want the barium to be expelled. Otherwise, it turns into something similar to concrete. So you do expect the stool to be white from the barium, and you want the patient to pass all the barium. So constipation is not a complication. Let's talk about a barium enema or a lower GI series. Installation of barium into the colon using the rectum or via the rectum. And what they're looking for are tumors, polyps, strictures, ulceration, and obstruction. To get the patient ready, they will be put on a liquid diet and a laxative the night before the exam. They'll have enemas the morning of the exam. X-rays are taken during the procedure to find out what's going on. After the test is over, cleansing enemas are used to remove the barium so it doesn't become impacted. And again, X-rays are repeated after the barium is expelled to see, what, if anything, is left. Let's talk about a paracentesis. A paracentesis is a needle aspiration of fluid in the abdominal cavity. It's used for diagnosis, or in some cases it's used for treatment. With paracentesis, the type of things that are frequently tested on the exam are, how do you get the patient ready? What is the preparation? What is the procedure? The care after the procedure and what complications may occur. So let's talk about getting someone ready for a paracentesis. Preparation for a paracentesis is you will position the patient in a semi-Fowler's position or sitting upright at the edge of the bed. The patient will be instructed to empty their bladder so there's no danger or risk of bladder perforation. Then the needle is inserted and the fluid is removed. After the test is over, you want to check vital signs. Again, you're removing fluid and you want to make sure that there's not hypotension due to fluid shifts. You would report any fever, if the patient develops a fever, or any abdominal pain because of the danger of infection, and you want to observe for shock, because that's one of the major complications after a paracentesis. Let's talk about a laparoscopy. Laparoscopy is a visualization of the pelvic cavity through the insertion of an endoscope, and there's an incision made beneath the umbilicus, and the endoscope is inserted to view the structures. You can use a laparoscopy to diagnose a problem or to treat a problem. They use a laparoscopy for a tubal sterilization. They use it for an ovarian biopsy, and they use it if the patient has adhesions to lice or to cut the adhesions. Getting someone ready for a laparoscopy. In preparing them, you need to let them know that a general anesthetic is usually used, and a Foley catheter or indwelling catheter is inserted. What they do for a laparoscopy is carbon dioxide is introduced. What it does is it's insufflated and it separates the intestines from the other pelvic organs so they can work in the area without having everything all pushed together. After the test is over, after the laparoscopy, the patient is allowed to be out of bed after the procedure and they resume their regular diet. Let's talk about a cystoscopy. Cystoscopy is a direct visualization of the bladder and urethra using an endoscope. Getting someone ready for a cystoscopy. They will do the bowel preparation like we've talked about before with the laxatives and enemas. Fluids are forced because, again, you need to have fluid in the area so you can see things. The patient will be NPO before the test is actually performed. Now, after the test, you want to monitor the character and volume of urine. There might be some hematuria, there might not be. But what you're looking for is abdominal distension, urinary frequency, and fever, which would indicate infection. The urine often is pink-tinged because of the cystoscopy, and often they will order antimicrobial prophylaxis. That's antibiotics used prophylactically to prevent the development of infection. After cystoscopy, moist heat can be used or sitz baths can be used for comfort. Let's talk about an IVP or an intravenous pylogram. This is X-ray visualization of the kidneys, ureters, and bladder using dye. What you need to know and what's frequently tested is the preparation, the procedure, what goes on during it, care after the procedure, and the complications. So to get someone ready for an IVP, you want to do bowel preparation, and we talked about that. That's the laxatives and enemas before the procedure is done. The patient is NPO at midnight. Before they ever are signed up for this, you need to check allergies, and the allergies you're looking for are shellfish, iodine, chocolate, eggs, and milk. Because of the dye that's used during an IVP, if they have these type of allergies, they are much more likely to develop an allergic response to the dye used for the procedure. You need to let the patient know that they may experience a burning sensation or may taste a salty taste when the dye is injected. And then during the procedure, during the IVP, x-rays are taken at intervals. After the IVP is over, you will check for a delayed reaction to the dye and the type of things you're looking for if the patient becomes dyspneic or difficulty breathing, if they wheeze, if there's edema, or if there's itching. This would indicate an allergic reaction to the dye and should be considered a medical emergency. Let's talk about a kidney biopsy. With a kidney biopsy, tissue is obtained by needle aspiration. Getting someone ready for a kidney biopsy. They will be NPO for 6 to 8 hours before the procedure. X-rays are taken before the procedure to locate the area where the biopsy is actually going to take place. And usually the skin is marked on the outside of the body at the lower pole of the kidney because that's where the biopsy is performed. To do the biopsy, the patient is positioned prone, meaning on their face, and bent at the diaphragm, and they're asked to hold their breath during the insertion of the needle. Now, after the test, again, one of the dangers you're looking for is hemorrhage. So what you need to do is make sure that pressure is applied to the site for 20 minutes. The patient is positioned prone, and a pressure dressing is applied. You're going to be checking vital signs very frequently, every 5 to 15 minutes for the first hour after the procedure. When the patient comes back to his room, he will be flat in bed on bed rest for 6 to 8 hours. And you're looking for hematuria or blood in the urine, and you're looking for bleeding at the site of the insertion. You'll also want to encourage fluids after this to 3,000 cc's per day. The next test or diagnostic test we're going to talk about is a Schilling's test. This is a test used to diagnose vitamin B12 deficiency. To get someone ready for this test, what you do is you give an oral dose of radioactive vitamin B12. A few hours later, you give a dose of non-radioactive vitamin B12. Because what you're doing is you give them the radioactive dose, you wait a few hours, you give the non-radioactive dose, and then the urine is going to be measured for radioactivity. You're looking to see how much radioactivity passed through the patient and is excreted in the urine. The normal amount excreted in 24 hours is greater than 10% of the dose that's given. Because what this means is if a lower amount, if just a little bit comes out in the urine, that means the patient has pernicious anemia, because it means that that first dose, that radioactive dose, was absorbed by the body. But a normal person without pernicious anemia, that first dose, most of it would just pass through the body because the body doesn't need it. It can absorb it regular ways, and it absorbs it again. The second dose will be absorbed and no problem. So a diagnosis of pernicious anemia with the Schilling's test will take place if a low amount of radioactive B12 is released after the test is done. And the reason it's a small amount is the body absorbed it because it needed it. That concludes our discussion of diagnostic tests. We're going to now talk about therapeutic procedures. Let's talk about Meniere's syndrome. You remember Meniere's is to the ear what glaucoma is to the eye. There's too much circulating fluid, and that's a good way to remember both of those disease processes. The type of things you'll need to know with Meniere's is you'll need to know the symptoms, and you'll need to know the teaching you do with the client. There are three major symptoms of Meniere's. First of all, there is incapacitating vertigo, which is kind of dizziness, and it can last anywhere from minutes to hours. There's tinnitus, which is a ringing or roaring sound in the ears, and there is fluctuating, meaning coming and going, sensory neural hearing loss, and usually it's on the involved side. The average age of onset for Meniere's syndrome is about 40 years old. Also, the patient may complain of nausea and vomiting, and they may have nystagmus. And remember, nystagmus is the eye deviation to the side. Let's talk about the treatment for Meniere's syndrome. They will use medications such as antihistamines. They will use anti-vertigo medications such as Antivert. They will use tranquilizers such as Valium. They will use antiemetics such as Phenagrin. They will use diuretics such as hydrochlorothiazide or HCTZ. And they will use vasodilators such as Pavabid or Banthine. When the patient is in the acute phase, the patient will be put on bed rest. And usually a low-sodium diet is prescribed. Also, dietary restrictions, they should avoid alcohol, nicotine, and caffeine. Let's go on, and we're now going to talk about cranial nerve disorders. And the type of things you need to know are how to care for a client with trigeminal neuralgia and how to prevent complications for a client with Bell's palsy. Those are the topics that are frequently tested. Let's talk about trigeminal neuralgia. It's also known as tic de la Rue, and it is involvement of the fifth cranial nerve. What the patient complains of is facial pain that lasts anywhere from a few seconds to a few minutes, and usually they say it's like stabbing and burning. There may be contraction of the facial muscles. Usually it affects people in their 50 years of age or older. And there are trigger points on the face that will start the pain. So you need to, and the patient needs to learn to use a lot of care Don't wash the face, shave, or chew, especially if they're having symptoms, because it will trigger the pain. The type of treatment they do for this, they want to do medications that will reduce the transmission of impulses, of nervous impulses, and analgesics. They use Tegretol, and they take it with meals in increasing dosages until pain relief is established. The food that the patients eat with the trigeminal neuralgia, the food should be at room temperature, should not be too hot or too cold. You should not jar the bed. You want to rinse the mouth after eating instead of brushing the teeth, because that may set off the pain. The patient should learn to chew on the unaffected side. They should be put on a soft diet so there isn't a whole lot of chewing involved, and they may do surgery. Another cranial nerve disorder is Bell's palsy. Remember, Bell's palsy is facial paralysis caused by problems with the 7th cranial nerve. The type of symptoms you'll see, the patient will have speech difficulties, and they will be unable to eat on that side because of paralysis. They can't close that eye, and there may be increased lacrimation or the tearing from that eye. Bell's palsy usually will spontaneously go away in 3 to 5 weeks. There's usually spontaneous recovery. The type of treatment they use for Bell's palsy is they will use prednisone to reduce inflammation and edema. They will use analgesics. They will use heat to the face. They will use electrical stimulation to help with the paralysis. They may teach the patient isometric exercises of the face. And you want to use a lot of care. Remember, they can't close the eye on the affected side, so it may need to be patched, especially at night, because you don't want the patient to experience a corneal abrasion. Another type of cranial nerve disorder is acoustic neuroma. Acoustic neuroma is a tumor of the 8th cranial nerve. The type of signs and symptoms you'll see, there may be deafness and dizziness. And what they do for acoustic neuroma is they will do surgery, and they'll do a craniotomy. So you would do the type of care for this patient as you would do after a patient undergoing a craniotomy. The next type of problem we're going to talk about in our sensory perception area is Guillain-Barré syndrome. This involves the cranial, spinal, and peripheral nerves. Usually the syndrome, the Guillain-Barré, is preceded by a gastrointestinal or a respiratory infection 1 to 4 weeks before the onset of the neurological deficits. It also may be seen after a person undergoes vaccination or postoperative after a surgery. What you will see is paresthesia, meaning tingling and numbness. There may be motor losses, and what they do is they usually begin in the lower extremities and go up. The patient may experience difficulty talking, chewing, or swallowing. They may have an altered heart rate, rhythm, and their blood pressure may be altered. Let's talk about the type of treatment you do for Guillain-Barré. The goals of treatment, first and foremost, is to improve respiratory function. Because again, we have difficulty swallowing, and we want to make sure they have a patent airway. You want to increase the client's mobility. You want to improve their nutrition. You want to make sure that they have a means of effective communication so they can communicate with you and others. You want to decrease their fear and anxiety because it is very fearful, and you want to make sure and prevent complications. So the type of treatment they use, the patient will be put on medications, and that's steroids. They may need mechanical ventilation in order to provide for respiratory assistance. The head of the bed will be elevated, and you want to make sure the patient is suctioned, again, to maintain a patent airway. Physical therapy may be ordered. Eye care will be ordered for the patient, and again, one of the biggest things, you want to improve respiratory function, and you want to prevent complications. Okay, let's talk about the symptoms you'll see for meningitis. The symptoms that the patient experiences comes from a combination of the infection and an increase in intracranial pressure. The early symptoms that the patients will have is headache, they'll have fever, they will be disoriented, and they'll have nuchal rigidity, which is a stiff neck. There will be changes in level of consciousness. They will have a positive Koenig sign. And Koenig sign is when the hip is flexed to 90 degrees, complete extension of the knee is quite painful. They'll also have a positive Brodinsky sign, and this is flexion of the neck produces flexion of the knee and the thigh. Other symptoms the patient will experience because of the increasing intracranial pressure is there will be a widening pulse pressure and bradycardia. There will be respiratory irregularities. The patient will complain of a headache. They may experience vomiting. They may have, again, the decreased level of consciousness that increases over time. They may have seizures. They may have a petechial rash, and this is especially seen with meningococcal meningitis. And if it's an infant, they will have bulging fontanelles and a high-pitched cry that is characteristic of the disease. Diagnosis of meningitis is done by cultures of the cerebrospinal fluid and the blood. The medical treatment will usually be a tracheostomy. The patient will be put on a mechanical ventilator. They will receive oxygen and rapid IVs. What you want to do is you want to monitor the arterial blood gases and the arterial pressures. You want to monitor the client's weight and serum electrolytes. You want to monitor the urine volume, specific gravity, and osmolality. Patient will be on droplet precautions until they've been on antibiotics for 24 hours. Other type of things, there will be IV antibiotics and antifungals, and again, you want to prevent complications. Now, we talked about meningitis, and one of the things that's important to remember is that there is a vaccine to prevent this. It's usually given to patients older or people older than 65 years old or people 2 years and up that have chronic diseases. Patients are revaccinated every 5 years, and people who are in close contact with people who develop meningitis are given prophylactic rifampin to prevent the development of the disease. Let's talk about a migraine headache. Remember, migraine headache is a vascular disturbance. It occurs most often or more often in women. There is a strong familial tendency. The highest incidence is 20 to 35 years old. The type of precipitating factors you'll see are stress. It has a relationship to the menstrual cycles of the woman. Bright lights, depression, sleep deprivation will bring it on. Fatigue can cause it. Foods containing tyramine or monosodium glutamate, nitrates, or milk products can cause it. The type of things you need to know about migraine headache are the precipitating factors that I just discussed, how to prevent it, and what the symptoms are of migraine headache. There are two phases of a migraine. The first is the prodromal phase, and about 60% of the patients have symptoms hours to days before the headache begins. And with the prodromal phase, the patient may become depressed, they'll be irritable, they will feel cold, they may experience food cravings, they may complain of anorexia, there will be a change in their activity level, and they may have increased urination. The second phase of the migraine headache is the aura phase, and about 20% of the clients with migraine headaches have an aura. And usually it's usually less than 1 hour in duration before the headache begins. And what patient will see during that time is they will see light flashes and bright spots. They will experience numbness and tingling of the lips, face, and hands. They may become mildly confused, become drowsy, and dizzy. Under assessment, the type of headache that they have usually is a throbbing headache that intensifies over several hours. About 60% of the patients have a unilateral headache rather than bilateral. The patient may experience photophobia, they may have nausea and vomiting, and usually the headache lasts anywhere from 4 to 72 hours. The next phase is the recovery phase, where the pain gradually subsides. The patient is usually left with muscle aches and local tenderness over the neck and scalp, and they may sleep for an extended period of time. Let's talk about prevention of migraine headaches. Medication therapy is carried out at intervals of 3 to 6 months and then gradually tapered. The type of medications they use are beta blockers, such as Inderol, because that inhibits the action of the beta receptors. Those are cells in the heart and brain that control dilation of the blood vessels. They also use calcium antagonists or calcium channel blockers, such as the verapamil, and it may take several weeks before an improvement is seen with the calcium channel blockers. Other medications are Sansert and Depakote. The patient may be put on antidepressants and barbiturates and tranquilizers. Under implementation, if the patient is experiencing a problem, they use medications such as Ergomar, which is a serotonin receptor antagonist. They use Imitrex, DHE, and they also use antiemetics. And the serotonin receptor antagonists cause vasoconstriction. They reduce inflammation and reduce the transmission of pain impulses. Other treatments you do for a patient experiencing a migraine, you will use comfort measures, you will use a quiet, dark environment, and you will elevate the head of the bed about 30 degrees. The next problem we're going to talk about is Huntington's disease. You'll remember this is a chronic, progressive, hereditary disease of the nervous system that results in progressive, involuntary movements and dementia. What happens is it causes premature death of the brain cells that control movement, thinking, perception, and memory. Huntington's disease is transmitted as an autosomal dominant genetic factor. Each child of a parent with Huntington's disease has a 50% chance of developing the disease themselves. The type of symptoms you'll see with Huntington's disease is depression. There will be personality changes. They may have coriform or dance-like movements. The type of treatment they do or implementation, they will put them on Librium, Haldol, or Thorazine, and supportive care is provided both to the client and to their family.
Now let's talk about some anxiety disorders, and the first is phobia. A phobia is an irrational fear of an object or situation that persists, although the person recognizes that it's unreasonable. There's some different types of phobias. For example, agoraphobia, or the fear of open spaces. Social phobias, where a person fears that they'll, get in a social situation and they'll be embarrassed or criticized. Or claustrophobia, the fear of closed spaces. And there's a whole list of phobias. Now, if you're dealing with a client who does have a phobia, they're going to feel anxiety when confronted with the feared situation or object. And they understand, or they may recognize, that their fear is unreasonable, but their fear is real. Now, with your nursing care, do not confront the client. Don't focus on them trying to be afraid. There's not a thing you can say to them that will make them unafraid. Systematic desensitization is a technique that's used that we talked about earlier, where a client is confronted with this feared object over short periods of time, and then their exposure to it will be more frequent and longer, so that then the client hopefully will become unafraid. It's also very important that you teach relaxation techniques, for example, deep breathing, the use of exercise, meditation, or progressive muscle relaxation. Another anxiety disorder is obsessive-compulsive disorder. Now, this can either be an obsession or a compulsion. Obsessions are repetitive, uncontrolled thoughts, or a compulsion is a repetitive, uncontrolled act. Now, again, the person may recognize that their obsessions or compulsions are excessive and unreasonable, but they can't stop them. The problem with obsessive-compulsive activities is it increases the client's distress and becomes very time-consuming. Now, mildly compulsive behavior can be valued. For example, here in the United States, we think it's important that people be on time for work. And how many of us watch the clock and know that we have to leave the house at 6:32 in order to walk in the office at 7:45? Now, that is a compulsion, but it's something that's positive. Other examples of compulsive behaviors that are okay are Lucky Charms, knocking on wood. I remember several years ago I had a nursing student who said to me she had one pair of underwear that she always wore when she took every test in nursing school, and she was wearing her Lucky underwear when she walked into her NCLEX RN exam. Again, an example of a compulsion, but it doesn't interfere with her ability to function. Now, at the other end of the spectrum, these rituals become so time-consuming that they interfere with normal routines and relationships. It's very important that you focus on the client rather than the symptoms, because what you want to do is increase their self-worth. So it's important that you provide for their physical needs, because they may be so involved with their rituals that they don't eat. So you want to encourage them to eat without getting into a power struggle. It's important that you accept the ritualistic behavior, but you're also going to contract with them. Yes, you can wash your hands for, 1 minute, but then we're going to move on to another activity. You're going to help them structure their environment. Because this is an anxiety disorder, you may need to limit their choices, so be aware of that. Stimulus response therapy, where the client learns that anxiety can be managed even though the compulsion isn't carried out, is also very valuable, as is group therapy, and also medications. Clomipramine, which is a tricyclic antidepressant, is used to lower the obsession with obsessive-compulsive behavior. Another anxiety disorder is conversion hysteria, and this is a somatoform disorder. So the client has unexplained symptoms or deficits affecting voluntary motor or sensory functioning. Now, what they experience suggests neurological or other general medical conditions. For example, you'll have a client that has seizures without losing consciousness, or they have physical symptoms without organic basis. Another indication is called labile indifference, and this is somebody who just tells you with a really flat affect and no real concern, I can't move the right side of my body. So it's an inappropriate lack of concern. Now, if you're dealing with a client who has a conversion hysteria, the very first thing that's going to happen is a complete diagnostic evaluation to rule out physical problems first. After they've ruled out the physical problems, when you're dealing with what the client is experiencing, it's important that you discuss their feelings rather than the symptoms, because what you don't want to happen is the client starts experiencing secondary gains from the symptoms. For example, getting out of usual responsibilities or getting the extra attention. So you're going to focus on the client's feelings rather than the symptoms. All right, well, now we are going to talk about crisis intervention, and it's one of those topics where you don't have to be working in the psychiatric area. You're going to be dealing with clients in crisis wherever you're working. Now, your need to know for crisis intervention is you need to know the assessment and intervention for a grieving client, for a dying client, and for rape trauma. Now, before we talk about those specifics, I want to talk just for a moment about what is a crisis. Now, a crisis is a period where there is a major change in a person's life, either from a real event or a perceived event. Crisis has several characteristics, and they're listed here. First of all, it's a temporary state of disequilibrium that is precipitated by an event or a perceived event. A crisis is self-limiting in time. It's of a short duration, usually about 1 to 6 weeks. Now, the positive thing about a crisis, it can promote growth and new behaviors because it gives the person the opportunity to develop some new coping skills. The types of crisis are listed here. The first is a maturational crisis, and this occurs with each new developmental stage. For example, you have your preschooler who now has to go to school. Well, that's a maturational crisis. Or the young person who graduates from college and now has to enter the workforce. That's another example of a maturational crisis. The second type of crisis is a situational crisis, and this comes from an external rather than an internal source. For example, a loss of a job or a loved one or a pregnancy would be examples of a situational crisis. Then you have the adventitious crisis, and this is a crisis of a disaster. This is an unplanned crisis. It's accidental. It's not a part of everyday life. For example, a natural disaster or a crime of violence would be considered an adventitious crisis. Now, when a person is confronted with crisis, they go through definite stages of crisis. The first is denial. This simply isn't happening to me. The second is anxiety. Now, when the person begins this or feels this anxiety, it's a positive because remember, mild anxiety stimulates problem solving, and that's a positive. Now, if that doesn't take care of it, then the person goes through this stage of disorganization. And that is their usual defense mechanisms don't work, and their anxiety continues to increase. The fourth stage is the attempt to reorganize. And in this case, the person simply uses trial and error to try to solve the problem, to restore their normal balance. The fifth is the attempt to escape, and this occurs if trial and error fails. The person, their anxiety increases to the severe or panic levels, and it's literally, I want to run away, don't want to deal with this, I can't deal with it anyway, I just want out of here. And during this time, personality disorganization may occur. Now, the last stage is general reorganization, and what has happened is the person has developed new or unusual problem-solving solutions and support. Their anxiety decreases, and they can go back to their pre-crisis level of functioning. Now, how do you care for a client who is in a state of crisis? Remember what your first goal is to maintain their pre-crisis level of functioning. In this case, the nurse is directive rather than non-directive. We're not going to explore, we're not going to do a lot of talking about, what is going on. We want to help the client solve the crisis because remember, it's self-limited. So it's very important that we focus on the here and now. We be very goal-directed. We need to evaluate the client's understanding of the problem. The more clearly the problem can be defined, the better the chance is that the client can find an effective solution. You would ask questions like, what led you to seek help now? Describe how you're feeling. You need to define the event and also confirm the nurse's perception. It's very important during a crisis that you help the client become aware of their feelings. Now, in doing this, you're going to avoid blame. You don't want to blame them for the problem, nor do you want to allow them to blame others. You want to help the client develop a plan. So you encourage the client to make as many arrangements as possible, making sure to write out all information because their anxiety level is high, and try to maximize existing support systems. You also want to help the client find new coping skills. The first way to do this is you find out how they've coped before, and you focus on their strengths. What did you do before and what worked? And then you encourage the client to reach out to others. The first type of crisis that we're going to talk about is a situational crisis, the grieving patient. Now, you know that grief is a self-limiting normal response to loss, and it's caused by separation, divorce, death, trauma, or surgery. Now, the grief reaction will be more intense if the loss is sudden, if it's a loss of a child. Perhaps there's unresolved conflicts between the person and the deceased, or the person has poor coping mechanisms. Now, there are stages to grief. The first is shock and disbelief. The person just says, no, this isn't happening. So back to that old denial. And this functions as a buffer against the pain. It allows the person to acknowledge the reality of the death or the change, but they don't have to feel the feelings that go with it. In this case, the person may act as a robot. They intellectually accept what's going on, but they haven't had the emotional responses yet. The second stage is the awareness of the loss, and this is where the denial fades and it's replaced by the painful feelings. Anger, guilt, crying occur during this stage. The acute period lasts about 4 to 8 weeks, and this is when we go through the rituals of mourning, viewing the body, funeral services, religious or cultural rituals, cleaning out the person's home, whatever is involved with these things. Usually the grief process is resolved in about a year. Now, if you're dealing with a family who is grieving, it's very important, do not leave your family alone. And these questions are going to come up on the exam. Now, while you don't leave them alone, you also don't want to be intrusive. You want to follow their lead and support them in the way that they would like to be supported. They may want to interact with you as the nurse, or they may want silence. So while you're not going to leave them alone, you're going to follow their lead. It's very important that you provide your family with privacy during this time of grief. As with all crisis intervention, we're going to focus on the here and now. We're going to accept their initial dependency of the grieving person or the family. It's very important that you encourage the client to verbalize their feelings and also let them know that the pain, the crying, the anger, the guilt that they're feeling are normal reactions. It's very important that you emphasize the client's strengths to increase their ability to cope with the situation. Now let's talk about the client who is dying. This too is a situational crisis. Now, I think we all are aware of the work of Dr. Elizabeth Kubler-Ross, who researched a person's response to dying. And the phases or steps that one goes through is listed here. First of all, denial. No, this isn't happening to me. And it serves the same function. It helps the person acknowledge what's going on without the feelings. The second stage is the feeling stage. It's the anger. The third stage is bargaining. If only I can live to watch my daughter get married, I will do. The next stage is depression. And this is just where the person realizes what is happening, and the last stage is acceptance. Now, when you're dealing with a client who's dying, it's very important that you keep your goals more short-term and more modest. When you're dealing with a client, for example, with a terminal illness, the goal is not to help them get better. Maybe the goal is that they will be pain-free, or perhaps they want to help them reconnect with an estranged family member, or to be comforted spiritually. In this case, the nurse is more facilitative than directive. Remember, we talked about the nurse being directive with a crisis, but here we want to facilitate what it is the client wants to happen. Very important that you keep your lines of communication open, and you do this through your therapeutic communication and being available to the client. You allow the client to express their feelings, whatever they're feeling, and, use reflection to reflect what it is that you're seeing. Very important, again, as with all crises, to focus on the here and now. Let your patient know that they are not alone. I know I used to do hospice home care, and with these clients, one of the things you always wanted to convey to them is, I'll be here with you if that's what you want. You don't have to die alone. You don't have to figure these things out by yourself. It's very important that you give the client a sense of dignity and control, and you do this by letting them take the lead, and then you following their lead. It's also very important that you provide physical comforting care. And it is last on this list, but certainly it isn't your last priority. You want to make sure that they're physically comfortable, that they are as pain-free as we possibly can make them, that room temperatures are comfortable, and they have the kind of food that they may want to eat. The next situational crisis that we're going to talk about is rape trauma. Now, this is sexual assault. This is an act of violence against a person in which the sexual act is a weapon. There are several different types of rape. The first is stranger rape, and I think when we think about it, it's probably the first type of rape that comes to mind. But also spousal and marital rape occurs, as well as acquaintance and date rape. Now, if a client has been raped, what the type of behaviors you may see is self-blame and embarrassment. You know, they blame themselves for even getting themselves into the situation and are embarrassed by it. They may fear violence. They may experience anxiety and insomnia. They may have a wish to move, to escape, or to completely relocate, to get away from the area, and they may experience psychosomatic disturbances. Now, there is an acute phase of the rape trauma syndrome, and this occurs immediately after the rape and may last for 3 to 4 weeks. And again, the most common, very first response, as with, all crises, is the shock, the numbness, and the disbelief. During this phase, the client may become restless or cry uncontrollably. Now, it's very important, if you happen to be working in an emergency department when the client comes in, that you do not leave your client alone. You're going to stay there with your client. It's also important that you maintain a non-judgmental attitude and caring. It's not the person's fault, and in no way are you going to convey that it is. It's also very important that you encourage the client to talk, and this is through that silence, through the empathetic listening. Maybe the client doesn't want to talk, but they will be comforted by your presence. Now, you're going to assess for injuries. You're going to take care of the physical. You might perhaps be involved in saving samples of tissue for evidence. It's very important, because this is a crisis, that you write out treatments and appointments. Don't expect the client, to remember things. And you may refer the client for legal assistance. Now, the client will go through a reorganization phase of the rape trauma syndrome, and this is long-term. Remember, the first phase lasts up to 3 to 4 weeks. So this phase begins at the end of the initial phase. During this phase, the client may have intrusive thoughts. They may have flashbacks. They may feel anger. They may just want to, their assailant, they'll just want to do them in. During this time period, the client may have increased motor activity. They may have crying, mood swings, depression, anxiety, and they may also develop fears and phobias. It's very important that you encourage the client to continue with counseling to resolve this crisis. Okay, let's talk about post-traumatic stress syndrome just for a moment. This is an anxiety disorder, and a client repeatedly re-experiences the traumatic event. And what I want to emphasize with you, it's not that the client just remembers it, but they're there again. So they're actually reliving all of the horrifying things that happened to them. They're feeling all the feelings that they felt at the time. This traumatic event can be combat, it can be rape, murder, or fire, and the response to this trauma is one of intense fear and horror. So what happens is a client is exposed to a traumatic event, and then they have a recurrent or distressing recollection of the event. They may have nightmares about it or flashbacks. And again, a flashback is not just remembering, it's reliving what happened. These flashbacks or nightmares can occur months to years after the event occurs. Now, when you are dealing with the client who's undergoing post-traumatic stress syndrome, one of the implementations or care is flooding, and that is we encourage the client to recall the event in as much detail as possible. Now, during this, you want to remain empathetic to the client and what they're experiencing, but also be non-judgmental. It's important that you challenge their ideas, point out irrational thinking. help the client recognize the limits of their control over the stressful event. You know, they couldn't control it. They can't control what happened, but they can learn to cope with their response to it. It's important that you label their feelings, and also that they learn stress management techniques such as meditation, the use of exercise, or you encourage them to attend a support group. Another strategy that may be encouraged is anger management, because sometimes the clients are angry about experiencing the event, so they may need an anger management program. As with all anxiety, and this is an anxiety disorder, you will encourage regular exercise because it's very helpful to them. You'll enhance their support systems. Encouraging a client to journal is also another very good implementation. It empowers the client, and hopefully what they'll get out of the journaling is that they do have control over how they respond. Now, clients undergoing or who are experiencing post-traumatic stress syndrome may also have sleep disturbances. So you want to help the client sleep again. So you'll want to encourage a regular bedtime. It's important that you encourage the client to use the bed just for sleeping or for lovemaking. No working, reading, watching TV. Inform the client that if they don't fall asleep within 30 minutes, they need to get up, move around, go to another room, read in a chair, and then come back to bed and see if they can go to sleep.
Okay, we've finished with talking about IVs. Let's talk about medications. Medications is an area that's often very overwhelming to students. I mean, there are thousands of medications, and how am I going to remember all the names and all the, the rates and the dosages and side effects and teaching? Well, the best way to learn medications is to learn them by category. Because if you learn them by category, and you know what the category does, and you know this is part of that category, then you know what it does. Also, if you know how a medication works, for example, it affects stimulates the sympathetic nervous system, and of course you know what the sympathetic nervous system does, then you can again figure out what the drug does and what the patient would expect, how it would be used and that type of thing. Again, one of the things to remember is when you're dealing with side effects, many times side effects are too much action. So if you know what the drug does and the patient is experiencing a side effect, sometimes that side effect is just the drug is functioning way too well and you're getting some other things going on. Now, the frequently tested medication, or the question that many times is asked on the NCLEX is, your patient is getting a particular drug. How would you know it is effective? So again, make sure you know if a patient, for example, is getting a medication as an anticonvulsant, how would you know it was effective? Well, the patient would not be experiencing seizures. So again, make sure you know about effectiveness of medication, because many times that's what they ask. The other frequent question asked on the NCLEX with regard to medications is, what would you teach the patient? And again, the type of things you'll teach the patient is they need to be compliant with the drug regime and take it as ordered. They need to know when to contact the physician when something's going wrong. They need to know what the side effects are. They need to know whether they take it with food, without food, in the morning, at night, those type of things. So again, the teaching that goes with medications is frequently tested. Don't worry about learning both generic and trade names. The test, the NCLEX, will give you both of those medications. Don't worry about learning dosages. Again, with probably just a couple of exceptions, and one of those exceptions is digoxin. Make sure you know both digitalizing and maintenance doses for dig. But most medications, the nurse does not decide how much the patient gets, the physician should. And while it is a nursing responsibility not to give medications outside of the normal dosage range, that isn't something that's frequently tested on the NCLEX. And one of the other things to remember is, back when you're in anatomy and physiology, you remembered that the liver detoxifies or metabolizes most medications, and then most are excreted by the kidneys. So again, knowing what the liver and kidneys have to do with medications, you can figure out some of the side effects that the patient may experience. Okay, so we are all set up. Let's talk about medications. The first ones we're going to talk about are the adrenergic. Now, let's talk first about how they work. This category of medications stimulate the sympathetic nervous system. So what you will see is an increase in peripheral resistance. You will see an increase in blood flow to the heart. You will see bronchodilation. You will see an increase in blood flow to the skeletal muscles. And you will see an increase in relaxation of the uterus. So those are the type of things that this category of medication does. Okay, knowing that, some of the examples of medications that are adrenergics are level-fed, dopamine, adrenaline, and Dobutrex. Okay, the action of these medications, again, they are sympathetic nervous system stimulants. They stimulate the beta-2 receptors in the lungs. It's one of the things they do. They are used for cardiac arrest and COPD. Let's talk about the side effects you will see with the adrenergics. What they can cause is dysrhythmias, they can cause tremors, and they have anticholinergic effects. And remember, the anticholinergic effects are the dry mouth, the urinary retention, those type of things. So nursing considerations for patients that are getting adrenergic is you want to monitor the blood pressure. You want to monitor peripheral pulses, and you want to check output, again, because of there may be urinary retention. When you're giving these type of medications, again, the patient may become a little sleepy or drowsy, so you want to make sure that they're not doing anything such as driving a car if they're experiencing some of the sedation that may happen with this. Another category of medications are your anti-anxiety agents, and some examples are Librium, Xanax, Ativan, Vistarol, and Equinil. What these medications do is they affect the neurotransmitters, and they are used for anxiety disorders, manic episodes, and panic attacks. Let's take a look at some of the side effects and nursing responsibilities. The side effects for these type of medications are sedation. Many times the patient will become quite sedated. The patient may become confused, and there may be hepatic dysfunction. What you want to do is to make sure and check the liver tests, which are your AST and ALT, to make sure the liver is doing fine, because again, this is a case where the liver detoxifies these medications. The nursing considerations or responsibilities for the anti-anxiety agents, there is a huge potential for addiction or overdosage with these medications, so they need to be monitored closely. While the patient is taking these medications, they should avoid the use of alcohol because it causes respiratory depression. And again, they need to monitor the nurse should monitor the liver function to make sure there isn't a problem. With these type of medications, you don't want to discontinue them abruptly. Patients should be weaned off them. And one of the things that's important to let your patient know is smoking and the use of caffeine decreases the effectiveness. So if the patient takes up smoking or drinks a Diet Coke, caffeinated Diet Coke every day, it will decrease the effectiveness of the anti-anxiety agents. The next category of medications we're going to talk about are the antacids. The type of antacids from examples that you may see are Amphigel, milk of magnesia, or Maalox. What these medications do is they neutralize gastric acids. These medications do not coat the ulcer. That's a different type of medications. These medications are used for peptic ulcers. They are used to prevent or treat indigestion, and they are used for reflux esophagitis. What the side effects you will see are they can cause constipation or diarrhea because they interfere with the GI tract, and there may be an acid rebound after the medication. With these type of medications, the nursing consideration, can interfere with the absorption of antibiotics, iron preparations, INH, remember medication used for tuberculosis, or oral contraceptives. If patients are getting antacids, and again, this is a frequently tested topic, you want to give them 1 or 2 hours after other medications. Again, 1 or 2 hours after medications. When patients are taking antacids, again, you want to make sure that you are checking their fluid and electrolyte balance, because sometimes both calcium and the phosphates can get messed up because they are contained in the antacids the patient takes. When the patient takes antacids, they should be taken with 1 ounce of water. And again, we talked about taking them 1 or 2 hours after other medications. The medications, the antacids, are usually taken 1 to 3 hours PC, which means after meals, and HS. Usually you don't take the antacid with meals because it then would cause a delay in gastric emptying, which would result in more indigestion and more problems. So again, key thing with antacids, 1 to 2 hours after other medications. They are usually taken 1 to 3 hours after meals and at HS. Let's talk about the antiarrhythmic medications. These medications decrease myocardial irritability. And some of the good examples you'll see with antiarrhythmics are atropine sulfate, lidocaine, pronestil, quinidine, and isoprel. What these medications do is they interfere with the electrical excitability of the heart. And they're used for atrial fibrillation and flutter, tachycardia, and PVCs. Side effects you will see with this type of medication is the patient may become lightheaded, the patient may experience hypotension, a decrease in blood pressure, and they may have urinary retention. One of the key things with the antiarrhythmic medications, and probably most important, is you need to monitor vital signs very, very frequently to find out what's going on and also monitor cardiac rhythm. Okay, let's now talk about antibiotics. And before we talk about antibiotics, there's a couple things that I think need to be said. Antibiotics, again, we're going to talk about the different families of antibiotics. And again, this is an excellent way. If you know that, for example, an antibiotic is an aminoglycoside, then you'll know how it works and what it does, what some of the side effects are. But some of the general side effects for all antibiotics, the first problem that we see quite often is allergy or hypersensitivity. This can range anywhere from a mild rash or hives, and this would be treated with antihistamines, to a severe allergy or hypersensitivity, and this is anaphylactic shock. And again, shortness of breath usually is your first symptom you will see with a severe allergy. And it usually will occur within 20 minutes of taking the medication. And the treatment for the severe allergy is epinephrine and bronchodilators. Again, remember, we talked about this, or we'll talk about it again later, is this is a medical emergency and the patient needs to have an airway and, go from there. The second type of general problem that happens as a side effect of antibiotics is a superinfection. Now remember, there's normal flora in your body that does good things. It keeps your GI tract running as it should. It keeps your mouth the way it should be. But antibiotics are not always selective. They don't always just kill bad bacteria. In some cases, they destroy normal flora. And if the normal flora is destroyed, an example of good is the mouth, the GI tract, the respiratory tract, the GU tract. Again, that can cause problems. So that's, again, one of the side effects is the superinfections that can happen because normal flora has been destroyed. And the third very common complication with all antibiotics, regardless of the family, is organ toxicity. And again, I think you know what organs I'm going to talk about. Remember, most medications are detoxified or metabolized by the liver and excreted by the kidneys. And the organs most often involved with problems with antibiotics are the liver and the kidneys. Okay, let's talk about a particular antibiotic family, and this first one is the aminoglycosides. Some of the examples you'll see for this are gentamicin, neomycin, streptomycin, and tobramycin. Again, the different families act different ways. The aminoglycosides inhibit protein synthesis in gram-negative bacteria, and they are used for Pseudomonas and E. coli. So that's kind of what they do and why they're used. Let's talk about some of the side effects you'll see. They can cause ototoxicity. Remember, ototoxicity is problems with hearing, and it's because it interferes with the cranial nerve. It can also cause nephrotoxicity. Again, remember, many of the medications are excreted by the kidneys, so we want to make sure and check renal function. Usually this type of medication, let's go back. Some other side effects. We talked about the ototoxicity. Some of the other side effects you will see are anorexia, nausea, and vomiting. And again, the aminoglycosides may cause diarrhea because they kill off the normal flora in the GI tract. Okay, nursing considerations. Again, we talked about the ototoxicity as a complication, so we need to check the 8th cranial nerve, or the one involved with hearing, to make sure the patient's hearing is not being destroyed. You'll also want to check renal function to make sure that the urine output is okay. You'll check the BUN. And again, urinary output should be a minimum of 600 cc's a day, probably more like 1,200 cc's per day. These type of medications usually are taken for 7 to 10 days. And one of the problems you experience is patients take it until they feel better, which isn't always 7 to 10 days later. Many times it's earlier, so they're non-compliant and don't complete the course of antibiotics. And that is a problem. Again, with these medications, because they can affect renal function, is you want to encourage fluids. Normal intake is 1,500 to 2,000 cc's a day, so if you're encouraging fluids, you would encourage them to 3,000 cc's a day. Now, one of the things I want to talk about also, and it's used with antibiotics, such as the aminoglycosides, is many times the physician will order therapeutic drug monitoring. And what that means is they will check both the high level and the low level of the medication in the system. It's called the peak and the trough level, because they want to make sure that, again, for these medications that have what they call a narrow therapeutic index, meaning this much is good, this much is too much, you'll have problems, and this much is not enough and you won't get the good effects of it. So again, a narrow therapeutic index, many times they will use what they call therapeutic drug monitoring. They will monitor both the peaks and the troughs of the medication. So what you want to do for the peak level is you draw it 45 to 60 minutes after the drug is administered, because this is its highest level, the peak. Again, we want to make sure if it goes too high, we're going to go from good effects into toxicity, and we don't want that to happen. Now, with the trough level, what you will do is you will obtain a blood sample just before you give it again. Because again, this is the lowest level, and you want to make sure the lowest level is not too low, because if it drops down so that it's supposed to be here and it's way down here, then that medication has been ineffective for a period of time, and they're not getting enough to kill the microorganisms that they should be. So again, remember, peaks are done about 45 to 60 minutes after the drug is administered. The trough is done just before the medication is administered again. And each individual medications have specific peaks and troughs that tell you that they are within their therapeutic index.
Another complication that you may encounter on the NCLEX exam is a placenta previa. Now, placenta previa is a placenta that's implanted in the lower uterine segment, usually near or over the cervical os. So what happens as the cervical changes occur during pregnancy, the placenta is torn away and it causes painless vaginal bleeding. So in the first and second trimester, it may be spotting, but third trimester is painless vaginal profuse bleeding. The client has no warning. All of a sudden, there's just a lot of vaginal bleeding, but absolutely no discomfort. Implementation for a client who has a placenta previa diagnosed is they will be on bed rest, either in a side-lying or a Trendelenburg position, at least for 72 hours after the bleeding begins. They will do an ultrasound to locate the placenta. Remember, no vaginal or rectal exams on these clients because you don't want to do anything to stimulate the bleeding. They will do an amniocentesis for lung maturity, and also you're going to be monitoring your baby very carefully for status because you want to make sure that your baby is doing okay. Mom, while in the hospital, will have daily hemoglobins and hematocrits. Also, you're going to monitor the amount of blood loss by counting the pads. When the client goes home, it's important that you teach this mother to limit her activity. No douching, enemas, or sexual intercourse. It's important that mama measures or assesses the kick count of her fetus several times a day. So she wants to make sure that her baby is moving and doing okay. And then this client will also have a non-stress test about every 1 to 2 weeks where Mom will come in, and remember, they'll put the monitors on her and make sure that the baby is moving and the baby has variability in the heartbeat. You have to be able to distinguish between a placenta previa and abruptio placenta. Now, an abruptio placenta is the premature separation of a placenta that is implanted in a position that it should be. So it's a properly implanted placenta, but it prematurely separates. It occurs due to maternal hypertension and cocaine abuse. Symptoms that you're going to see include painful vaginal bleeding, Remember, the placenta previo is painless vaginal bleeding. This is painful vaginal bleeding. The abdomen is tender, it's painful, it's tense. You may assess fetal distress, and the client may be having contractions. Now, any blood loss that you see, or many times the blood loss does not match the symptoms. You've got a client who has symptoms of shock, but yet you may only see minimal blood loss of dark red bleeding, and this is because they're bleeding inside of their bodies. As far as the implementation goes, you're going to monitor for fetal distress. Again, remember, the blood loss is not going to necessarily match the symptoms, and you can have a rapid onset of fetal distress, so the baby has to be monitored very, very carefully. This client is prepared for an immediate delivery because the placenta is already separating. Postpartum complications that you look for after the surgery or after the baby is removed via C-section is disseminated intravascular coagulation, or DIC, which is treated with anticoagulants, pulmonary emboli, infection, or if the client has had a large amount of blood loss, you may have renal failure. Another complication that you may have to care for in your practice of nursing or see on the NCLEX exam is maternal diabetes. Now, there are several clients who are at risk for maternal diabetes, and what you're seeing on the screen are the diabetes increased risk for these things. What I'm talking about now is that there are certain clients that we are concerned that may develop maternal diabetes. These are clients who are age 25 and older. They are obese. They have a family history of diabetes in a first-degree relative. They are a Hispanic, African American, Native American, or Asian American, and they have a history of abnormal glucose tolerance tests. So if a client has any of these risk factors, then what they will do is they will do a 1-hour glucose tolerance test from 24 to 28 weeks. So again, remember, we're trying to prevent, and if we can't prevent, we're going to manage early. Now, if a client does develop maternal diabetes, they are at risk to develop maternal infections, pregnancy-induced hypertension, hydramniosis, which is greater than 2,000 cc's of amniotic fluid, and then that causes preterm labor, macrosomia, or large for gestational age infants, but then they may have immature organ systems, congenital anomalies, prematurity, respiratory distress syndrome, and ketoacidosis. Symptoms that you're going to see of gestational diabetes, and these are people who were not diabetic but developed diabetes during pregnancy, is hyperglycemia after 20 weeks. The gestational diabetes is usually controlled by diet. They're never given oral hypoglycemics because of the tetragenic effect of the medication. So the client is either controlled with diet and exercise, or they receive insulin. Care for your client with gestational diabetes includes frequent need for careful monitoring throughout the pregnancy. This includes careful monitoring of the mother in her diabetic situation, but also careful monitoring of the fetus. It's important that you teach the client and at least one significant other about the importance of eating a prescribed amount of food at the same time each day. The client needs to learn how to do home glucose monitoring. Also, if the clients are not able to be maintained on diets, if their blood sugars keep going up, then they will have to be taught how to administer insulin. So there would be all the implications with that, the purpose, the dosage, how to administer, what the actions, side effects, any potential changes they may need during the pregnancy. If the client perhaps early on was started on insulin, what they need to know is that, and this is for any diabetic, that due to the increase in human placental lactogen and also an increased resistance to insulin and a decreased glucose tolerance, clients will require more and more insulin during the pregnancy. So toward the end of their pregnancy, their insulin dose may quadruple from what it was earlier. Another disease that you may be dealing with is cardiac disease in pregnancy. Now, you remember what happens with pregnancy. Increased cardiac output occurs, which increases the heart rate and also an increased blood volume. If your client has a decreased cardiac reserve due to cardiac disease, it's much more difficult for their hearts to cope with the increased workload. So when you have a client with cardiac disease and who is pregnant, it's very important that you monitor them for chest pain, for shortness of breath, and also monitor their vital signs frequently. Now, these clients will be graded according to their functional capacity. For a client who has a class 1 or class 2 heart problem, they will have a normal pregnancy. If they're class 3 or class 4, then there will be issues with them coping with the changes due to pregnancy. Treatment medically depends on the functional capacity of the heart, and also the type of delivery will be influenced about whether the mother can handle the labor and delivery process or perhaps will be C-section. For your clients with cardiac disease, it's important that you encourage rest, but along with the rest, they need moderate activity. They need to avoid people with upper respiratory tract infections because these guys don't need to get sick, and they also need to be alert to the signs and symptoms of heart failure. Let's talk now about another complication of pregnancy, and this is a hydatidiform mole. Now, this is a molar pregnancy. You have a pregnancy that started out normally, but due to a degenerative anomaly of the chorionic villi, you end up with a hydatidiform mole. Symptoms include elevated HCG levels, a uterine size that's greater than expected for the due date. Because there is no fetus, there will be no fetal heart tones, and the client may be bleeding, minimal amounts of dark red or brown vaginal bleeding, and they pass these grape-like clusters. Clients will have nausea and vomiting due to the elevated levels of HCG. And it's also associated with pregnancy-induced hypertension that occurs prior to 20 weeks of pregnancy. Treatment includes curettage to remove all of the molar tissue because there's a remote chance that this molar tissue can develop into a choriocarcinoma. Because of the danger of cancer, these clients are monitored very carefully for a year, and they discourage pregnancy for 1 year after the hydatidiform mole was diagnosed. It's important to tell the clients not to use an IUD. Now, there's some more complications that you need to know for the NCLEX exam, and it has to do with preterm labor, identifying who's at risk for preterm labor, and also how do you care for the client in preterm labor. We're going to talk about care of the client who's being induced as well as the client who has to have a cesarean section. Now, preterm labor is clients that go into labor prior to the end of the pregnancy. Risk factors for preterm labor include an African American woman, a client that's older than the age of 35 or younger than the age of 17, lower socioeconomic status, previous preterm labor or birth, people who smoke or abuse substances such as alcohol or drugs, or there's just a general problem with the pregnancy. And the problems with the pregnancy include placenta previa, abruptio placenta, or an incompetent cervix. Now, implementation, how are we going to be caring for these clients? Well, unfortunately, clients with preterm labor are placed on bed rest in a side-lying position. It's very important that they monitor the uterus for contractions and also weigh themselves daily. They need to have a good, balanced nutritional intake. Sometimes if clients can feel themselves developing contractions, relaxation techniques will also help. They're also given medications, which are the beta mimetics, such as Utapar or terbutaline or breathine. Now, please know that these medications are smooth muscle relaxants, and so that's why they relax the uterus, but they also may cause pulmonary edema. It's also important throughout the process, if somebody's experiencing preterm labor, that you carefully monitor your fetus. Now that we have talked about Erickson, and please master Erickson because he will be on your test, let's talk about growth and development. And this is growth and development through the lifespan again. Now, you know that growth is more rapid in utero during infancy and adolescence. There are specific developmental tasks or skills and competencies associated with each stage, and we've alluded to them with Erickson, and we're going to continue talking about them. We also are going to talk about the developmental milestones, the standard reference to compare a child's behavior. And this is very important on the test and is certainly frequently tested. It's also important that we're able to identify developmental delays or the lags behind a given range. Now remember, growth is a process. Remember, its sequence is orderly and predictable. Coordination and control develops from head to toe first, from the trunk to the periphery, and gross motor skills to fine motor skills. Growth also tends to be cyclical. And remember that what we're going to be doing is evaluating our children and also evaluating the parents to make sure that they're fostering growth and development. Okay, first we're going to go through infancy, and we're going to go through it month to month because there are so many dramatic changes. Now, first of all, during the first 6 months of life, a child gains about 5 to 7 ounces weekly for the first 6 months. So this is the way that you're going to be evaluating the children's charts. You're going to be evaluating the children's weights on a chart. Children generally like toys, soft clothes, or blankets, or rocking crib to play with during this early infancy. Let's talk about, first of all, the 1-month-old. Now, I think the main thing is your 1-month-old, if you bring them to a sitting position, their head is going to sag, so they don't have head control. By 2 months of age, they've mastered this head control. You will see closing of the posterior fontanelle. The child is able to turn from side to back, and it's 2 months that the children develop a social smile. Now, toys that you're going to offer the child includes mobiles, wind-up infant swings, and again, soft clothes or blankets. They're real tactile. And you're going to encourage your parents to hold their children close to their faces. That's called the on-face position, where mom holds the baby or dad holds the baby this way and really gazes into the child's eyes. You want to encourage your parents to talk and sing to the children. Yes, they don't necessarily respond at this age, but they need that kind of stimulation. And last but not least, they need to be cuddling and rocking their infants. Okay, for the 3-month-old, this is when the children learn to bring objects to their mouth, and their head is erect. They can raise their head and shoulders from a prone position, bearing weight on their forearms. It seems to be a common position that you see babies. If you see a baby picture and they're lying flat and they're pushing up, looking around, that's a 3-month-old. They can clutch their own hand and pull blankets or clothes toward them. They squeal out loud. They are interested in their surroundings. And it's important at 3 months that you encourage your parents to place their children in an infant seat and take them into the various rooms. So if dad has been sitting in the family room and yes, the baby's in a pumpkin seat and the baby's safe, rather than just leave the infant there, dad's going to carry the baby to the bedroom and going to be interacting and talking with the infant all the time. Also, it's important that you encourage your parents to exercise the baby's body by moving, perhaps in a swimming motion or the legs in a cycling motion. A 4-month-old, at this age, they've mastered thumb apposition, or they've developed thumb apposition, and they begin drooling because they may begin in the early stages of teething. It's at 4 months that the tonic neck reflex disappears, as well as the Moro reflex and the rooting reflex. Now, a 4-month-old can sit erect when propped. They're able to roll from their back to their side. They're able to grasp objects with both hands, and they can carry an object to their mouth. A 4-month-old can laugh and show excitement. It's important that you encourage your parents to place their children at this age in front of an unbreakable mirror, because the children really like looking at the image in the mirror. Also, repeat the sounds that the infant makes. During bath time, you just don't want to bathe the child and get the child out of the tub. Another thing you can encourage them to do is sit and play or splash around, because this will aid in their development. At 5 months of age, the birth weight has doubled. So this is an important evaluation that you are going to do. When a 5-month-old is sitting, they can hold their head steady and erect. They can turn from back to abdomen, so the child can now completely turn both ways. They can play with their toes, and this is when they begin to be able to discriminate strangers from family members. A 6-month-old begins teething and turns from back to stomach. Well, it can either be 5 or 6 months for that. They gain, starting at 6 months, about 3 to 5 ounces a week for the next 6 months. They're able to sit in a high chair with a straight back. They can hold their bottle. If the child is holding one cube and you hand them another one, they'll drop the first one and take the second one. They vocalize to toys and mirror images. Now they definitely recognize their parents and begin to fear strangers. And you should encourage your parents at this age to begin labeling body parts. This is your nose, this is your fingers, this is your belly button, this is your toes. And it's also important that you tell the infants what you're doing. We're going to go into the kitchen, and it's time that I get dinner started, because this communication is so very important. You want to be interacting with these babies all the time. At 7 months, your infant can sit for short periods of time, and this is when they really begin fearing strangers. And we'll talk more in just a moment about separation anxiety. The 7-month-old, when you hold them in a standing position, they bounce up and down. They're able to transfer objects from one hand to another. It's at about this age that the children begin banging objects on tables. So whatever is in their hand, they're going to be pounding it on the table. A 7-month-old can respond to their own name, and it's at this age that they try to attract attention by coughing and snorting. They'll cough and cough and cough until somebody looks at them and smiles and says, are you talking to me now? And then they'll continue the behavior. 7-month-olds, you can play peekaboo. They'll imitate the motion. When you play peekaboo, they'll repeat the motion also. At 8 months, this is when the fear of strangers is at its strongest. An 8-month-old can sit unsupported. This is when they begin developing the pincer grasp, which is the fingers against the thumbs. They're able to combine syllables with their vocalization. Again, you're going to encourage your parents to continue labeling body parts, and again, tell the parents to explain to the children what you're doing. Toys for this age, the 7 and 8-month-old, include large toys with bright colors. They like colored blocks, and also playing with the Jack-in-the-Box. Your 9-month-old can elevate themselves to a sitting position. This is when they can begin to say da-da, which is always so meaningful to parents. Your 10-month-old is able to crawl well, and they can pull themselves to a standing position. Now, again, remember with these gross motor skills, use the textbook. You may have had a child that was crawling rather well at 7 or 8 months, but according to the textbooks, a child crawls well at 10 months. Toys that you're going to offer the child include anything that has noisemakers, large toys with movable parts. But remember, you're always going to be aware of the toys that you're giving your children. Nothing with small parts that are small enough that they can pull off and put in their mouths and then choke. Let's go on to the 11-month-old. At this point, the 11-month-old is standing erect, is standing erect with support. At 12 months, the birth weight is tripled. Star this because this is something that's certainly important. Remember, birth weight doubles at 5 months and triples at 12 months. A 12-month-old is eating with their fingers at this point, so they're probably eating safe foods off the table. At 12 months, the anterior fontanelle is almost closed and the Babinski reflex disappears. It's important at this age that you encourage your parents to read nursery rhymes to the children and also imitate the sounds that animals make. Toys for 11 and 12-month-old include books with large pictures, push-pull toys, teddy bears, a large ball, or sponge toys. Let's talk about the introduction of solid foods because this begins in the first year of life, usually around 4 to 6 months of age. Now, principles that we're going to follow that you're going to teach your parents is they should only add one food at a time. So they should add a food, wait a couple of weeks, and then add a second food. It's important that we give the least allergenic foods first and then work toward the allergenic foods. So they're all delayed until children are a little bit older. Usually cereal is the first food that's introduced, and this is because of it's easily tolerated by the infants and because of its high iron content. Rice cereal is many times because it's the most easily digested. It's the first cereal that's offered. When you instruct your mothers or parents about offering their babies rice cereal, it's important to tell them how they mix it up, that they mix it with formula or breast milk or water, but they do not use cow's milk or whole milk. After 6 months of age, then the cereal can be mixed with fruit juices. Fruit juices, when offered to the children, should only be offered in a cup because if you offer it in a bottle, this causes the development of dental caries or cavities. So to prevent dental caries, juices are only offered in a cup. Now, the next for vegetables or fruits or vegetables, it really doesn't matter which order they're given in. Many people suggest that you go with the vegetables first so the children don't get used to the sweet taste of the fruits. So after the cereal, you will offer vegetables. After the vegetables, you will offer fruits. After the fruits, you can offer potatoes, and then you can offer the children meats. Now, usually citrus fruits, meats, and eggs are delayed till after 6 months of age because of the potential for allergies. When meats are first offered, you will grind the meat up very fine so that the children are able to eat them safely. At 6 months of age, you can also offer your child crackers or Zwieback toast. At 9 months, junior foods, and at 12 months, the child should be able to eat well-cooked table foods. So by 12 months, the children should be eating the same meal as the parents, as long as it's not rare meat. It's also important that you don't give honey to your infants under the age of a year old because of the danger of botulism.
Let's talk about some general nursing care for patients that have cancer. First of all, patients should receive good mouth care. Many of the patients with cancer will be on chemotherapy, and stomatitis or inflammation of the mouth is something that commonly develops about 5 to 14 days after chemotherapy is started.
There may be ulcers and bleeding and soreness. Again, the patient should rinse with saline. They should use a very soft, bristled toothbrush. They should not use drugstore mouthwashes because many of them contain alcohol, which would be very irritating to the tissues. These patients, again, should have foods that are not real hot temperature-wise, meaning really hot to the touch. They should also not have a lot of really spicy foods. Sometimes the patients will take antifungals or anesthetics, again, to help with the mouth pain. Another nursing issue is to make sure that they meet their nutrition needs, and usually patients with cancer are put on high-calorie, high-protein diets. Again, both the chemotherapy, the radiation therapy, and the cancer itself can cause nausea and vomiting or anorexia, so we want to make sure that the patient's nutritional needs are met. We want to make sure that they are in an anabolic state rather than a catabolic state. So you would have small, frequent feedings. There may be nutritional supplements that are given between meals. You want to encourage fluids, but again, it would be helpful if the fluids were given between meals rather than with meals, because then the patient would be apt to eat more. And after meals, again, good oral hygiene, and pain relief before mealtime, again, would encourage the patient to take more nutrition in. Let's talk about pain relief. With cancer, again, pain is a huge issue, and we want to make sure that our patients don't spend a lot of time in pain. They use a ladder approach with this. For mild pain, they use non-narcotic medications such as Tylenol. They also use antiemetics, antidepressants, and glucocorticoids to decrease inflammation. For moderate pain, they use weak narcotics such as codeine and other stronger non-narcotic analgesics. For severe pain, they use strong narcotics such as morphine. And again, remember when you're dealing with pain, it's better to medicate the patient more frequently. They will end up spending less time in pain. So you'll want them to take, or you will give them the pain medications on a regularly scheduled sequence or schedule, so they can take them with a preventative approach. You don't wait till they're deeply in pain. You give them the medication to prevent it. Okay. Other things, general nursing care to go with patients with cancer. Many times there are significant body image changes that go with this disease. And again, you want to encourage the patient to verbalize their feelings. You want to encourage them to participate in their care. You want to allow them to make any decisions that they can themselves. Again, it gives them a sense of control where possible. Again, the medications are antiemetics, analgesics, and antidepressants that the patient will be taking. Let's talk now about the types external radiotherapy or external radiation that is used to treat cancer. And these are the nursing responsibilities that you as the nurse will do, and you should also teach the patient. First of all, with external radiotherapy, they will put markings on the patient's skin, so each time they come in for a treatment, they will be able to line up the machine, because you want the radiation targeted to the area of cancer. Now these, while in these markings, again, if it's on the head or neck, they can be, again, they can cause a body image change because you have kind of like, arrows and boxes on your face. But patients need to know to leave those markings on. It's essential so that the radiation can be delivered where it should. You do not want the patient to use creams or lotions. The only type of cream or lotion that would be acceptable would be vitamin A and D ointment. Other creams and lotions contain things that will interfere with the external radiation. You want to check for redness and cracking because, again, the patient may develop kind of sunburned appearance, like they've been outside too long. And, again, you want to, give care for that. They should wear cotton clothing, again, because it breathes and it's less irritating to the skin. And, again, antiemetics are used, and they're used before the patient has the external radiotherapy to prevent the development of nausea and vomiting. Let's take a look and talk a little bit about internal radiation. And with internal radiation, it can be given two ways, either with a sealed source or an unsealed source. Let's talk first about internal radiation with a sealed source. What this does is they mechanically position a source of radiation in a body cavity or into the tumor itself. So it's sealed, it's in the tumor, inserted in the body. The patient will be in a private room. There needs to be a lead container with long-handled forceps in the room in the event that the implant gets dislodged. All dressings, all bed linens are saved and kind of stockpiled in the room until the implant is removed. That prevents the accidental, the implant comes out, people don't know that, they gather up the linens, take it to the laundry, and now the people in the laundry have live radiation in their midst. So all dressings, all bed linens are saved in the room until the source is removed. Now the thing to remember, and you might say, well, oh gosh, I've got to be careful here. Well, the urine and feces are not radioactive because, again, remember, this is a sealed source. The radiation is being delivered in a very targeted area. Now, that said, you do want to take some precautionary measures. You would not stand close to or in line with the source. For example, if there was an implant put in the cervical area, you would not stand at the foot of the bed, which would be in a direct line with the implant. And again, you stand as close as you need to, and not any closer than that. So you do not need to go right up next to the patient unless there's some reason for you to do that. This patient will be on absolute bed rest. You do not want them up and walking about the room. Again, it may cause dislodgement of the radioactive source. Let's now talk about nursing care for internal radiation with an unsealed source. This is where a unsealed liquid is given orally or instilled in a body cavity, and the important thing to remember is that then it is absorbed by the body. So one of the things that is crucially important to know is the fact that all body fluids are contaminated. This is urine, feces, sweat, and the greatest danger is within the first 24 to 96 hours. Let's now talk about some of the nursing care for just internal radiation, either with a sealed or an unsealed source. The thing to remember, and the most important concept, is the fact that time and distance matter. You want to spend limited amount of time, and you want to have the greatest distance from the patient or the source of radiation that is possible and still get what you need to get done. These patients will be in a private room. There will be a sign on the door that says, "Caution, radioactive materials." Nurses will wear a dosimeter at all times. And some people think that this protects the nurse against the radiation. It doesn't protect the nurse. It monitors the amount of radiation the nurse is exposed to, so it can be measured. You want to limit visitors, and again, the nursing personnel or the healthcare workers should spend limited amount of time in the room. You spend enough time in the room to get the work done, but not any more time than that. And also in the rooms, there will be a shield that the nurse or the healthcare worker can stand behind while just talking with the patient, again, to decrease the exposure of the nurse. Staff should be rotated through the room, and no pregnant nurse should care for this patient. One of the other things important, and again, it goes back to the time spent with the patient, we want to encourage these patients to do as much of their own care as possible. So if they can give their own bath, change their own, clothes and all, we want them absolutely to do that. Let's go on and talk about leukemia. Leukemia is a frequently tested topic on the NCLEX, and the most common questions deal with bone marrow aspiration or the nursing care for patients with leukemia. The type of assessment you'll see, there'll be ulcerations of the mouth. The patient will have symptoms, and their lab will show that they are anemic. They will be fatigued. They'll have weakness and pallor. Now, you remember that leukemia is a fatal neoplastic disease that involves the blood-forming tissues of the bone marrow, spleen, and lymphatic nodes, or lymph nodes. It's abnormal. It's uncontrolled. There's destruction and proliferation of different types of blood cells. One of the things I said that it's important to know is the bone marrow aspiration. Let's talk just a minute about that because, again, it is frequently tested. You want to make sure that the patient or the parent, if it's a child, signs the informed consent. Usually the bone marrow aspiration is done at the iliac crest or the sternum. A local anesthetic is used because the procedure is painful. and then a sterile dressing will be applied to the area with pressure after the procedure is done. Now, there are different types of leukemias. There are acute leukemias that have very rapid onset and progress very quickly to a fatal outcome. There are chronic leukemias. These have a more gradual onset and a more prolonged course. Let's take a look at the nursing care you will do for patients with leukemia. Well, you'll want to monitor them for signs of bleeding, and these would be things checking for petechia, the bruising or area of ecchymosis, thrombocytopenia, again, because the blood formation of the thrombocytes and things needed for clotting will be abnormal. You want to monitor for signs of infections. This would be changes in vital signs, again, neutropenia, a white blood cell count less than 5,000, or fever and chills. You want to make sure these patients have good mouth care, because that is a problem. They should be on a high-calorie, high-vitamin diet. They will be put on what we call neutropenic precautions. And let's talk for a minute about what that means. It means that the patient will be in a private room. You'll limit the number of people that go in and out of the room to limit exposure to bacteria and diseases. The patient will have their WBC count assessed or done daily. No fruit, no flowers, no potted plants in the room, because again they may carry bacteria. The patient should clean their toothbrush with either a weak bleach solution, or if they're home they could put it in the dishwasher. The patient, for the intake, we talked about the high calorie, high vitamins, but they should avoid salads and raw fruit and raw vegetables, again, because of the chance of pathogens. They should avoid pepper or paprika, again, because that could cause a problem. The patient should not reuse a cup. When they drink from a cup, they should put it aside, and the next time they want to drink a water, they should get a new cup. And these patients, if they have pets, especially cats, should not be changing the litter box. They should not be out digging in the garden, again, because of the danger of pathogens. Medications used for leukemia are the chemotherapeutic agents and the antiemetics, and we talked about those in the pharmacological and parenteral therapies unit, and please do review those. They may also use chemotherapy or radiation for patients with leukemia, and they might also have a bone marrow transplant.